Hello everybody, I hope you're having a good day. I'm going to go ahead and begin narrating our nursing care of the client with specific endocrine conditions. We will be particularly talking about hyperthyroidism, hypothyroidism, and the other two are hyperparathyroidism and hypoparathyroidism. But let's go ahead and begin. I absolutely enjoy discussing these because I feel like it's pretty black and white what this organ does, some of the manifestations. I feel like a lot of conditions that we study, some symptoms can fall under one or the other, but this to me makes perfect logic. Your parathyroid and your thyroid have very specific functions. Your parathyroids are in charge of calcium, and your thyroid is all about metabolism and a little bit of calcium control too. So the effects of having too much or too little are going to just 100% directly affect the body in that way. So let's go forward and see exactly how. Get my clicker, there we go. Okay, so it all begins in the hypothalamus. What happens here is something stimulates the regulatory system, such as the hypothalamus here, to produce this hormone here. This is thyrotropin releasing hormone. Not really important for you to know at this moment, but just know if we have a tumor here, then you're going to have a problem all the way down. But anyway, so the body senses, hey, I have a low temperature, hey, I have a increased metabolic rate, whatever the stimulus may be, but it's going to release this. The anterior pituitary gland is going to know that it needs to start producing thyroid stimulating hormone. So it gets the signal, hey, let's start working, or it doesn't get the signal, anterior pituitary just kind of sits there. Regardless, let's just stick with the state of hyperthyroidism because that's what I'm about to speak to. But it gets the signal that we need to go ahead and start producing some thyroid stimulating hormone because we need the thyroid to work. So this is only made to target this gland here. The TSH doesn't work on anything other than the thyroid. Well, the thyroid gets the stimulus and says, I'm going to start producing 3 hormones, the T3, the T4, and the calcitonin hormone. So it begins to produce these hormones, and it goes throughout the body, and all the cells, every single cell in the body is going to have an effect from the T3, T4, and the calcitonin. What's really neat about this is that in this whole feedback system, when the body meets the demand of whatever stimulus it was, say it was a low temperature, and the body starts making, starts releasing more energy, somebody's temperature starts rising, the body will sense through this, basically the computer, the brain here, says, oh, I'm good now. And so it's going to stop releasing this, and it's going to stop stimulating that, and stop producing this, which stimulates this to produce that. Ooh! So that's a little bit of how this works. But we can have a problem up here at this level and at this level for a person who has hyperparathyroidism. Most of the time, we have a problem at the thyroid gland. And we're going to move forward, and I'll tell you why that is the case. So we have somebody who has excessive T4, T3 levels in calcitonin. How do they get that way? Like, what is going on inside the body that makes the T3 and T4 and calcitonin be excessive? Well, the main reason is because of an autoimmune problem. So the body actually will create fake TSH. So that's the hormone that stimulates the thyroid to start producing all of these things. They've looked into why and how, and it is still unknown what causes the body to do it. There are some findings that medication can, exposure to chemicals, But in general, it is still unknown why the body will create fake TSH, or some people like to say an antibody, an autoimmune antibody, I should say. So anyway, the body creates it, not sure why, and then the thyroid just responds by increasing T4, T4, T3 calcitonin levels. Another reason you can have hyperthyroidism, not as common, but you can actually develop a toxic multinodular goiter. So what this is, it's very rare, but the thyroid just starts developing these little masses on it. It can be benign, meaning it just stays local to that organ or to the thyroid, or it can be malignant. But that can truly happen in any type of cancer of an organ. But when you refer to cancer and the thyroid, they call them toxic multinodular goiter, where it's going to produce a lot of the hormone. Another reason is exogenous hyperthyroidism. It's interesting, but for folks who have hypothyroidism, they have to take synthetic TSH, more or less. And so if a patient is not being very good in, say, getting their levels tested every 6 months or a year by a doctor, because sometimes it does change, the person could actually be taking too much TSH and put themselves into a state of hyperparathyroidism as they're treating their hypothyroidism. Kind of accidental, but it does happen. So a lot of times when you're doing teaching for somebody who has hypothyroidism, you're going to say, hey, watch out for the signs and symptoms of too much. So is too much a good thing in this case? No, it's not good. Bad. Some of the risk factors. So risk factors. What makes one person get it over the other? Well, I will say strong association if somebody has diabetes, rheumatoid arthritis, and vitiligo. That's whenever you have those white patches on your skin. They're thought to be caused by either sun exposure or through some kind of autoimmune issue, but you just get those white patches like on your face and eyes, nose, around the mouth, even the genital area. So some people think it's not to sun exposure. Well, hopefully you're not getting sun exposure. Well, I don't know. It depends. All right. So some of the risk factors are for that you want to think of when you think of hyperthyroidism is runs in the family, if you have rheumatoid arthritis, and if you have those white patches. it does increase your risk for Graves' disease. Another thing is that women more so than men get this condition, and it usually happens if you're anywhere from like 20 to 40 years of age. It can occur later, however, like in your 80-year-olds and such, but more than likely you're going to see it during that time period. As far as history, like what are you going to ask? So the questions you want to ask, particularly about heat intolerance. So are they in a normal temperature room and are they sweating? Do they seem uncomfortable? In fact, it may be something very benign to the patient that they can't go outside without just drenching in sweat, or if they're in a normally comfortable room, for others they feel like it is besides themselves. You know how if you've ever been with anybody who's had menopause and they have those hot flashes? I mean, you're normal and they are acting like they are in a desert baking in the sun, and clothes are coming off. They're wearing, bare minimum because they are just so heat intolerant. So that is the hallmark sign of hyperthyroidism, is their heat intolerance. I'll say it one more time. That is a hallmark symptom described by patients for hyperthyroidism is once again, heat intolerance. Another thing you want to ask about is some vision changes. Have they had any sort of like blurring, difficulty reading? Reason being is that, I know, tiring of the eyes. Do they feel like their eyes are just so worn out? In fact, a lot of times people with hyperthyroidism go to an eye doctor for help when in the case they have a thyroid problem because they start having these vision changes. But anyway, that is the earliest sign that somebody is developing hyperthyroidism, is the vision changes. So the hallmark, what is it again? Heat intolerance. Earliest is vision changes. But so ask about their vision changes, ask about their heat tolerance or temperature tolerance, I should probably specify. Then you're going to ask, have they had any, surgeries, particularly thyroid surgeries? Now, even just manipulation of tissues near the thyroid, you want to ask about. So I should probably rephrase that. Don't specifically ask, have you had thyroid surgery, which you'll get there, but start with, have you had any surgeries in your neck? So, because sometimes they can fuse your cervical spine by doing an anterior approach, which is right through the front of your neck, and they may actually bump and stimulate the thyroid to go into a state of hyperthyroidism. So ask if they've had any neck surgeries, and then specifically ask any thyroid surgery, or if they've been treated with any kind of thyroid hormone. So you're going to ask that, and then move to behavior. Have you had any behavior changes that you've noticed? Okay, so the expected findings for somebody who has hyperparathyroidism goes directly with somebody who is in a hypermetabolic state. So when we speak about, let's move straight to the GI system. They are going to be burning some serious calories. So they're going to have some weight loss, as evidenced by the safety pin. But they're going to have some serious weight loss. I mean, it can even be up to like 10, 20 pounds. Their GI tract is going to be really fast moving, so they're going to have lots of episodes of diarrhea. In fact, that contributes, in addition to them having burning a lot of calories cellular wise, but they can't absorb anything that they eat because of their gut is moving so fast, so it just goes right through them. Their tremors, their hands are going to be so shaky. In fact, that's one thing that they will describe in terms when they describe their anxiety, because they'll say, I'm so anxious, like even my hands are shaking. Like, okay, well, actually, that's part of the hyperthyroidism. So just kind of put those two together. Their hair, they will lose a little bit of hair, but not so much like they will in hypothyroidism. But it's going to be really fine. In fact, it's going to lose its texture. And remember I said intolerance to heat, that's a hallmark of hyperthyroidism. Now, not in all types of hyperthyroidism, only in Graves' disease, that's the autoimmune condition, will you have the bulging of the eyes. I have a slide that has a picture of that, but it can be bilateral bulging, or it could be unilateral bulging, where only one eye has this kind of scared look. In fact, what happens in this hyperthyroidism is that the eyelid muscles actually swell and contract, so they're actually being pulled back into the head, and the fatty tissue behind the eye is actually increasing, so it pushes the eye forward, and it is very disturbing to look at, particularly for a patient. And I'll say that it doesn't it doesn't go away very quickly, if it goes away at all. In fact, I was reading around on the internet, and so a plastic surgeon was actually giving a demonstration to patients and discussing that, he said that after somebody receives treatment, it takes about 2 years for the bulging eyes to fully go away. However, it can take up to 5. And he said after 5, if it doesn't go away, then they could perform a surgery to help the bulging eyes, look more normal. But yeah, so having hyperthyroidism fixed is not a quick fix for the eyes. So you have to tell your patient to, it is disturbing to look at, but it's it will, hopefully go away. If not, we can do surgery on it. Facial flushing, because they're just in that hypermetabolic state. Now, a goiter, that's the enlarged thyroid that you see here. When you take a look at your patient, they will have a goiter with hyperthyroidism. They can also have a goiter and hypothyroidism. So just because you see goiter, don't automatically think hyperthyroidism, because you can have it also in hypothyroidism. But for here, the reason you have a goiter is that remember the body makes a fake TSA hormone, and the thyroid is like, oh man, I need to respond. I need to become overactive. I need to make more, T4 and T3, and so it actually will grow the thyroid. Now, so this is very characteristic of Graves' disease. All of this is characteristic of hyperthyroidism, but this particularly just to Graves' disease, the autoimmune, and down here. So not particularly just localized edema. More specifically, it's pretibial mixed edema. So you will have skinny, and then right here, they are going to be really swollen. It's going to have this orange peel not experience. Oh wow, what's the word? Appearance. Yep. It's going to have an orange peel appearance where it's like swollen. It's kind of shiny. The book describes it as waxy, but it's on the front of the legs. And so when you look at it, it's going to be lumpy. It's going to be kind of ugly. But just kind of put this, the pretibial mixed edema with this, and you know that this person has the Graves type of hyperthyroidism. This is another key indicator. They're going to have pretty much no to irregular periods if it's a female. So that's another thing you're going to ask a patient regarding this. Now, it's uncomfortable, but do ask about their libido, because it is going to increase. In fact, they're going to have a very high sex drive initially, and it's followed by a progressively declining libido. So just kind of keep that in the back of your mind. This is an example of exophthalmos, and as you can see, the eyes have a protruding look to them. A test you can do to see if somebody does have exophthalmos, well, besides looking at them, is to have them glance down, and when they look down, their eyelids won't drop. They'll actually stay in the retracted position. And then the second test you can do is you have the patients look up, and their bottom lid won't go up when the eye looks up. It stays down as well, because both of them are retracted back. But go ahead and hit play, and once you're done watching this, you can click to the next slide. I would like to cover what lab test are you going to run on somebody who has hyperthyroidism. And the first test and most common test you're going to see are the T3, T4, and the TSH. And so what we're going to be looking here is for the elevation of those levels. Well, particularly the T3 and the T4. Now, in fact, when we have somebody with Graves' disease, as you can notice here, the free T3 and free T3 and free T4 are both going to be really high. That's because the problem is within the thyroid. And you're going to notice that the TSH is low. That is because there's nothing wrong with the pituitary gland. It's not getting any kind of feedback through that negative loop that we mentioned earlier, that things need change and that there's a problem. So this is a very important indicator whenever you have a low TSH and a high T3 and T4, that there is a problem, and probably the patient has Graves' disease. Now, to most certain know if this is Graves' disease and to separate it from, say, the toxic thyroid adenoma or the other ones, you have to draw an antibody level, and you do an antibody for TSH receptor antibodies, which is the TRAbs. So if you check this level out and it's high, that's the imposter TSH, basically. If that's high, then you know this person has Graves' disease. Now, you can also draw an immunoglobulin level of the TSH. In fact, that's on page 1288. And so that is the real good indicator that it is Graves' disease as well. It's normal in all other types of hyperthyroidism. Just know TSH is going to be low, high, and then you need to draw an immunoglobulin and or a antibody level to determine if it's Graves' disease or not. Excuse me. We're also going to do a thyroid scan. Well, we used to do these a lot, but not so much anymore, because you can't do them for somebody who has, I believe, bad kidneys, if they're allergic to iodine, or contrast, especially if they're pregnant. Sometimes this disease pops up in pregnancy. So there's a couple of contraindications to having this procedure. If they're allergic to shellfish, they can't do this, or they just have to have a lot of pre-meds to desensitize them. What you do is you actually administer this medicine about 24 hours in advance. It's actually a radioactive isotope. The person does not need to be in radioactive isolation when they get prepped for this, but the person will administer it to them orally. They swallow it, and then they scan them about 24 hours later and see how much of this material is absorbed by the thyroid. It should be I think I read 5 to 18%. Nope, excuse me, 5 to 35%. And if it extends beyond that, so the thyroid uptakes it in 45%, 88%, anything greater than 35, then they know that you have a hypermetabolic thyroid. All right, the most common test that you're going to run is an ultrasound. So that's when they can just determine the size, the general composition, if you have any masses or nodules on it. It's quick and easy, and that is one of the big indicators that they know that the size is enlarged. It has, benign or malignant tumors on it. I don't think there's any else I need to tell you. ECG, I didn't mention it on our last slide, or maybe the one before that when I was discussing signs and symptoms, but when we have somebody who is in a hyperthyroid state, they are going to have some heart issues, and they're going to be tachycardic and hypertensive. Because remember, the body is overstimulated, so they're going to be tachycardic and hypertensive. So fast heart, high blood pressure. Now, the thing about this is we actually had a patient this week over at West Florida Hospital, and the family member was speaking to us and discussing how he's got to go and have an echo and an EKG done. And so he was mentioning it was for his AFib, but the doctor was thinking it was because his thyroid had been having some trouble. And so he was going to get his thyroid level checked and his heart. So I thought that was quite interesting of a correlation there, that we actually had somebody with this problem. as we're studying it. So EKG, you're looking for arrhythmias and you're looking for tachycardia. Okay. Let's look at the non-surgical management of hyperthyroidism. The first thing you're going to do is monitor those vital signs. Remember, your body is in a hypermetabolic state, so your temperature has a tendency to be on the higher side. Now, what you want to look out for is if you develop a high fever and severe hypertension. So we're talking like 200 over, 90 or 110. In that event, your person is possibly developing a a thyroid storm. So a thyroid storm is a medical emergency. It's 1 degree increase, and then coupled with severe hypertension. And this person needs some emergency help, which you would have to actually call the doctor and get some order for some iodine preparations. But anyway, so always be looking out for the temperature, always be looking out for an increased heart rate. So I'm not talking like 60 to 80 or even 80 to 100. We're talking heart rates from like 110 to 140, 150, even 160. So those are heart rates that a person cannot tolerate, and they'll probably start showing signs and symptoms of distress at that point. So you're more than likely going to have a person on some telemetry 24/7. So you can watch for arrhythmias, you can watch for the heart rate and wave changes within the EKG. We're also going to be monitoring their nutritional status. So this person is going to have some weight loss. I'm unsure about the exact pounds, which is considered malnutrition for a person, but probably 10 to 20 pounds if a person's normal weight is considered too much. So we need to give them a high protein, high carb meal to try to restore what they're losing in their hypermetabolic state. So more in because more is going out. Also, they're going to have some diarrhea, so we need to make sure we look at their diet choices to make sure they're not eating things like, God forbid, prunes and high dairy products and things that get their bowels moving. So we're going to give them the opposite, what we call a low residue diet or a low fiber diet, to slow it down. And this way they can also absorb more food because the gut's not so fast anymore. We want to reduce stimulation. So this person is extremely irritable. They have, quick behavior changes. So they'll go from laughing to crying in a matter of moments. They're so unstable. We need to create an environment that's calm, that's consistent. In fact, if you have to deliver bad news or maybe a poor outcome, make sure that this person has support, because they will not be able to handle anything other than something that's just neutral or good news. Minimize energy expenditure. So if they have a couple of ADLs that you need them to do, such as like bathing, ambulating, changing their clothes, really eliminate the non-essential. And if they need to just bathe, okay, bathe at this one point in time. We'll save the walking and changing clothes for another period of time, because they do get tired quickly. It's kind of an all or none. So they're either all energy expenditure or they're all fatigued and tired and restless. Promoting comfort. So remember, they are heat intolerant. So that room temperature is going to be very cool. Leave it cool. Don't try to adjust it to something that is to your taste. Make sure it's nice and cool for them, because they're going to sweat frequently. And in the event that they are still sweating, make sure that they get cool showers, not these hot showers, because this person does have a temperature problem and a tendency to be on the higher end, so not hot water. Cool showers, frequent bathing to clean their skin of sweat. This person can also be at risk for dehydration with all that sweat, so make sure their fluid is replaced during this time of crisis. Now, drug therapies. What drugs are you going to give this person? I plan to talk a little bit more about this in class, but just to kind of briefly review it, we are going to give them some anti-thyroid drugs initially. And the drugs I'm thinking of in particular are methimazole and propylthiouracil. Now, the methimazole is a good one to give because it doesn't hurt your liver like the other one. However, here's my paper. Pregnant women or women who are not on birth control cannot take methimazole. It's not good because it can harm the fetus, and or if a person is breastfeeding, it is not the drug of choice for them. If they do want to get pregnant and they need this treatment for hyperthyroidism, then their drug of choice is the propylthiouracil, or PTU as we say. PTU is safe for pregnant women. However, the pregnant women or just anybody on PTU needs to double check their have their liver function checked. They need to kind of watch out for the yellowing of the skin or the eyes, just so we know that the liver is okay. It happens. And in that case, you would switch them to something else. If somebody is in a thyroid storm or they're prepping for a thyroid surgery, then they are going to get an iodine preparation. So these iodine preparations, I think the most popular one is called Lugol solution, but you would mix this in some juice because it tastes horrible, and you're going to make sure the person uses a straw when they take this because it can stain their teeth. But anyway, if somebody is having a thyroid storm or a cardiac manifestation of hyperthyroidism that they can't control, then you are going to give them this Lugol solution. So just make sure that you do not give it to a pregnant person or anybody who's nursing. Not a good thing to do. Now, lithium, this is actually a good treatment for hyperthyroidism. In fact, it is one of the main causes of hypothyroidism. What it does is it actually decreases the synthesis of the thyroid hormones, so that in this situation is a positive effect. So we actually will give patients lithium. Now, you may notice for mental health, you also give lithium, and I think this is for like bipolar mania episodes. So this is kind of a twofer because your patients with hyperthyroidism are a little bit on the irritable behavior, negative behaviors will be exhibited. So this is a twofer. Now, beta adrenergic blocking drugs or beta blockers. Why are we giving somebody beta blockers who has a thyroid problem? Well, if you remember, cardiac side effects are very dangerous for this patient. So if they're severe enough, we need to give them beta blockers, and particularly propranolol. That one is a beta blocker that is going to decrease our heart rate for us. It also does work on the blood pressure. So like any of your blood pressure and heart rate medications, make sure that their heart rate and their blood pressure are high enough, and that you just don't give this pill and you take them who are already lower. So there's required pre-assessment data before you give this beta adrenergic drug. So please know, you're not giving this for the thyroid, you're giving this for the side effects of the thyroid, if that makes any sense. Your eyes, remember those eyes have the exophthalmos, so they're big, they're wide. This person is at real risk for having dry eyes and corneal abrasions and lacerations. So this person needs lubrication, and sometimes they actually need eye drop steroids. And this is because it gets really dry and really red, and you have to sort of, decrease the inflammation the local inflammation on the eye, because if not, this person will have really poor vision. So, if all else fails with all of these things, well, no, I wouldn't say it fails. In addition to these things, sometimes you do have to go for surgery. And I'm going to go ahead and click on forward and just start discussing those nursing interventions. Okay, radioactive iodine therapy. This is becoming more of an outpatient therapy. I remember on the oncology unit we would actually have a handful every now and then, these radioactive iodine patients, and it was so nice to have them because they are a complete self patient, so they're taking care of themselves, they clean themselves, there's nothing you have to do for them. They have to bring all of their home medications that they need to take, and you just literally go walk and pop your head in for like 5 minutes and say, "Hi, how are you doing? Do you need anything?" And so a lot of patients opted to do this in the hospital because they didn't have the opportunity to be at home because they had like small children, they had infants, or somebody in the house who would be nursing and they couldn't be around them. So they would opt to come to the hospital to receive the radioactive iodine therapy. So this person actually takes I-131, and that is a radioactive isotope, and it's going to destroy those hormone-producing cells in the thyroids. It's pretty cool, but sometimes the dose isn't strong enough, so the person will actually have to come back 2 or maybe even 3 times to completely kill off the thyroid. That sounds crazy, but yes, you are actually poisoning the thyroid. In fact, when you do this, a patient is in radioactive isolation, and they have to stay in there, I think, for like 3 days or until their what's that thing? I think it's called a Geiger counter, until the Geiger counter reads a low amount of radiation is being emitted. But they have in their body fluids all of this radioactive isotopes. And so if they use the bathroom, they have to like double flush. If they use eating utensils, they have their saliva on the eating utensils. So it's recommended that they have disposable eating utensils. What else do I want to... Oh, if you spill, say, a body fluid, that's actually not a good thing. The hospital, I know, if we spilled, say, urine that had the radioactive material waste in there, we would actually have to wait till the patient, like, you can clean up with some towels and you keep the towels in the room, and then the person from nuclear medicine would come up every day with a Geiger counter and measure the radiation emitted every day after the patient was discharged, so we could then begin cleaning everything. So it's kind of crazy. But the person who has radioactive iodine therapy needs to be patient because it takes like 6 to 8 weeks for the therapy to truly work and for the body to start coming back to normal. You may want to tell family members this as well so they don't get distressed. There is a table. It's on page 1290, chart 63-4. This is very important to note in case you have patients that you need to discuss this radioactive iodine therapy, in the home setting. So, all right. So a lot of times if this doesn't work, or there's a contraindication, say that the person's already pregnant or they can't tolerate, being home or being away for so long, you go straight for a total or subtotal thyroidectomy. So this is where a surgeon goes in, usually an ear, nose, and throat doctor, and they will totally take out the thyroid gland or parts of it. If you take out part of it, you may or may not need medication therapy. If you take out all of the thyroid, then you're definitely going to need thyroid hormone replacement therapy. So it's good to know if the patient had a total or a subtotal. There are lots of things that can go wrong. Oh my goodness. The first one and most important one, they're both kind of important right here. Hemorrhage. Now, this can also be external hemorrhage, but more importantly, internal hemorrhage, which can be dangerous as well. So what you're going to be looking for in the first 24 hours is this complication here. You're going to look at the back of their neck. Don't forget the back of their neck, because a lot of times whenever they bleed, it will be draining and going down the side of their neck to their back. So ask the person to sit up a little bit. If you have like moderate amount, say 50% of the drain of the dressing is soiled, no big deal. Don't worry about it. If the thing is saturated, you're going to call the doctor. And internal hemorrhage is also just as dangerous, because this can cause tracheal compression. So be checking for the patients, like dressing, look behind them, and report excessive bleeding. And it is normal for them to have a drain. They're probably not going to go home with a drain, but they're going to have a drain in their neck. Respiratory distress. So a lot of times the swelling can cause respiratory distress, in addition to the spasms that a person can have from being intubated and to have their throat manipulated. So they're going to have a hoarse voice. Expect the hoarse voice. There is nothing wrong with a hoarse voice, but if they have something called stridor, that's whenever they exhale, and it is a really, I'll have to see if I can find an example for you on YouTube, but I don't even want to demonstrate it now. You know it when you hear it. You know it when you hear stridor, but it's just a high pitch, it's like a wheeze on steroids. That's what stridor reminds me of. And you can hear it literally outside a patient's room. This is a respiratory emergency. So if you hear stridor, make sure you get help. This person probably will have to get trached, unfortunately. In fact, you are going to keep a trach in the room at all times when you have somebody who has this procedure. Oxygen needs to be handy, and don't forget your lovely suction, so keep that set up before this person arrives. Now, when somebody has a thyroid taken out, sometimes the parathyroid, which controls calcium, sits right on top, and it gets stunned because of all the manipulation, or even damaged from a total thyroidectomy. Usually they do good procedures to preserve it, but it happens. So you're going to be measuring somebody's calcium levels pretty frequently. And you're going to be measuring their level of muscle irritation, which is for hypocalcemia. So tap their trigeminal nerve right in front of their ear, and if their mouth twitches, they have a positive, I'm going to mess this guy's name up, Shavak sign. And then if you put the blood pressure cuff, they curl their hand, that's a positive Trousseau sign. Also, their reflexes are going to be hyper reflexive. They're going to be very twitchy. What else? Oh, and always ask them if they have numbness at the mouth and numbness of the toes and fingers. I'll say it again. Always ask them, in fact, every single hour, do you have numbness in your mouth or numbness in your toes and fingers? This is a emergency situation where you need to administer calcium gluconate or calcium chloride IV. And at this point, this is whenever you ask for a rapid response team, just because administering calcium gluconate or calcium chloride is more of an emergency drug. Okay, laryngeal nerve damage. This results in the hoarseness. Unfortunately, it may last a long time. So let the person know that it's not permanent. It's from the intubation. It's not an emergency. Just continue to drink fluids, rest your voice, don't speak, and it goes away in just a matter of a few weeks. but it's kind of, what's the word, distressing to the patient to hear their voice. I have had a couple of patients say that their voice is permanently hoarse from this kind of procedure, but I wouldn't say it's common. Thyroid storm or thyroid crisis. So in the event somebody is having a thyroid storm and you've given them the iodine preparations and their thyroid still isn't responding, that's whenever you need to take them into surgery. Oh, I probably should mention the key manifestations for this: fever, tachycardia, and some really high hypertension. Very high. The eye and vision problems of Graves' disease, I think I already kind of mentioned it. You can, in fact, that's what that gentleman was talking about in the previous video. He went and had a global decompression, where that's actually where you take out some volume in the eyeball and the tissue behind it to make the eyes go right back into place so you don't have that startled look. I'm not sure why I don't have it on here. Well, pain management, don't forget pain management. That's probably a given, but pain management is important for this person, and they need to not hyperextend their neck. That position is when you will, I guess, like if you look up too high or if you don't have a pillow, your chin goes back and up, and that's a hyperextended position. So we want the head in a nice normal neutral position, maybe even looking in a downward type of angle. So make sure the head is comfortably placed on a pillow, and if they are to cough, sneeze, or anything of the like, or even sometimes sitting up, to splint their neck incision. So placing a hand on the dressing and sort of supporting the skin so they don't dehiss the wound, because that's always a fun phone call to the doctor. Ooh, I'm still recording. We'll try to keep it in silence. I was thinking actually on something. Remember how I mentioned the thyroid storm is one of the indicators for this procedure to happen? That's correct, but here I have in my notes to myself, if you have a subtotal thyroidectomy, it's the manipulation of the thyroid that's remaining that can also cause a thyroid storm or thyroid crisis. So you don't have to worry about this one if you have a total thyroidectomy. However, you do have to worry about this if you have a subtotal thyroidectomy. So, what are your signs and symptoms of that? Don't forget high fever, tachycardia, hypertension. Make sure this person gets their iodine type of drugs, to like the methimazole or the propylthiouracil, to reduce the production of more thyroid hormones. Make sure you give them beta blockers. Keep them cool, keep them calm. You may have to give them fluids if they develop shock. Hopefully that's never the case. But Oh, I do want to add, to bring their temperature down, would you use aspirin or would you use Tylenol? You actually want to make sure you give this person Tylenol, never aspirin, because that actually increases the thyroxine levels. Something, I don't know, don't ask me how or why it does it, but make sure this person gets Tylenol and not aspirin. Okay? That's all I have to say on that one. Well, I kind of just covered all of that. There's not really much more to say. I hate when I get ahead of myself. Suture line pressure, that's holding and guarding and supporting the incision. All right, question time. Everybody up, question time. All right, so here's a question for you. Let's see if you can get it. A nurse is reviewing the manifestations of hyperthyroidism with a client. Which of the following findings should the nurse include? Select all that apply. A. Anorexia. B. Heat intolerance. C. Constipation. D. Palpitations. E. Weight loss. F. Bradycardia. Read it again. A nurse is reviewing the manifestations of hyperthyroidism with a client. Which of the following should the nurse include? Select all that apply. A. Anorexia. B. Heat intolerance. C. Constipation. D. Palpitations. E. Weight loss. And F. Bradycardia. Let you think on that a second. Okay, the correct answer is heat intolerance, palpitations, and weight loss. It is not anorexia. In fact, your person's going to have an insatiable hunger. It's not constipation because your person's going to have diarrhea. And it's not bradycardia. Your person's going to have tachycardia. So good job if you got that one correct. I'll maybe do one more question. Let's see. Okay. A nurse is providing instructions to a client who has Graves' disease and has a new prescription for propranolol, a beta blocker. Which of the following information should the nurse include? A. An adverse effect of this medication is jaundice. B. Take your pulse before each dose. C. The purpose of this medication is to decrease production of thyroid hormone. Or D. You should stop taking this medication if you have a sore throat. Let me read it again. A nurse is providing instructions to a client who has Graves' disease and has a new prescription for propranolol, a beta blocker. Which of the following information should the nurse include? A. An adverse effect of this medication is jaundice. B. Take your pulse before each dose. C. The purpose of this medication is to decrease production of thyroid hormone. D. You should stop taking this medication if you have a sore throat. If you answered B, you are correct. Propranolol can cause bradycardia. The client should take their pulse before each dose. If there is a significant change, he or she should withhold the dose and call the doctor. Very good. On to hypothyroidism, and I promise to go through this a little bit faster. So in hypothyroidism, you do have a couple of causes, but the most common cause is the primary hypothyroidism. This is when the actual thyroid gland becomes dysfunctional. It can be an autoimmune thing as well. As you remember, Graves' disease was autoimmune. It can also be an immune issue within the thyroid. And in this case, we call it Hashimoto's disease or Hashimoto's thyroiditis. In fact, it attacks the thyroid. The thyroid notices that it's not producing enough. Well, not the thyroid. It's actually going to be the hypothalamus notices that it's not producing enough T3 and T4. So with that negative feedback system, we're going to get more secretion of the thyroid releasing hormone as well as the thyroid stimulating hormone, and this causes the thyroid to actually grow because it's responding to the TSH, but it's not producing the T3 or T4. So you're going to have a goiter in somebody who has hypothyroidism. That's the same as somebody who has hyperthyroidism, but just kind of pay attention, there's a goiter in both situations. But anyway, so in primary hypothyroidism, you've got an autoimmune cause. It can also be caused because of some medications that decrease the synthesis of thyroid hormones, such as the lithium, and also a drug called amiodarone. This one's pretty popular to use for somebody who's got really bad lethal arrhythmias that's not controlled by just beta blockers. So you have to put them on a drug called amiodarone, but this can cause hypothyroidism. Another couple of reasons why you develop hypothyroidism, well, let's just say that they did the radioactive iodine treatment for hyperthyroidism, or they surgically removed it. Now, that case, that's a not permissible hypothyroidism, but it's expected. Now, it's very rare, however, if somebody doesn't take enough iodine in their diet, such as a third world country, they can also fall victim to hypothyroidism. And that's a very uncommon cause in the United States, since we have salt that has iodine in it, and seafood and shellfish, a couple other things have iodine in it. But it does happen where they'll develop this condition. In that case, you would just do a diet change. But some of the signs and symptoms of hypothyroidism really just look like aging. So many cases of hypothyroidism, mild cases, let's just say, will go undiagnosed for years, actually. It doesn't happen until somebody goes for their routine checkup, or for when the disease is pretty advanced, does somebody notice that, hey, I got actually a low thyroid, I need to get that checked out. So many times it goes undiagnosed. That's the whole point of that statement there. This just describes that it is the absolute opposite of having a hyperactive thyroid. So everything in the body is going to be going slow, extremely slow. And you name it, from the heart to the digestive system, to the energy level, to the skin, to the hair growth. It is the complete opposite of hyperthyroidism. I would like to describe myxedema and the myxedema coma on the next slide. Stay with me. That's a certain type of swelling. Okay, so in hypothyroidism, they are going to be very, very intolerant to cold. In fact, they literally will be inappropriately wearing jackets and long sleeves and mittens and everything that they can, because their body is not able to produce enough energy to keep the temperature up. So they're going to be very intolerant to cold. Their hair is going to be falling out. In fact, their hairline will start going back and back and back. And this is not a genetic thing. It goes. They're going to be very lethargic, tired. In fact, we're talking sleeping 14 to 16 hours, and even still not feeling like they have enough energy to do anything. They're going to be constipated. Remember, it's the exact opposite of hyperthyroidism. So their gut is going to be so slow. Their hair and their nails and their skin even is going to be extremely brittle and break, and it's going to have lots of ridges in it. So if you ever get somebody who has untreated hypothyroidism, be sure to look at their nails. It looks like they're in need of a manicure, but that's really just the disease that it is. Their tongue is actually going to be a bit thicker, and that's because of the edema, the mixed edema that's going to be coming into play. What happens here is it's not true edema, which is fluid in the cells. It's mixed with a little bit of fat and water. So the person's not going to have any pitting edema if you were to try to push your thumb inside or in their skin. But the mixed edema is definitely going to be noticeable on somebody's face. In fact, their face, their eyes, their hands, their feet, they're going to have non-pitting edema. And once again, this is called mixed edema, and it's not going away anytime soon. In fact, it takes weeks for it to actually go away. Cardiovascular wise, here we go. They're going to have bradycardia and hypotension. So their blood pressure is actually going to be a little bit on the lower side. And they're probably going to have some dysrhythmias as well with it being so slow. When it comes to getting their speech out, thinking of things, being intellectual with you, they're going to have trouble. In fact, you're going to assume that they're more or less dumb, but that's not the case. They have a underlying condition going on. Also, weight gain, that's another thing that they have is evidence here. It's a late clinical manifestation. So when they start gaining weight, you know that the disease is starting to advance. Their voice, because they actually have edema that develops in their larynx, it's going to be really hoarse and really raspy. It's going to sound like they're a smoker. How do you like that one? So be on the lookout for a hoarse voice. Their menstrual periods, remember for hypothyroidism, they're going to be absent or spotty. Here they're going to be very heavy. They may have an absent period, but it's going to be generally heavy. Decreased libido, so they could care less about sex. They could probably have a naked person in front of them and it would not do a thing. Fatigued, I think I covered that one. Just making sure. In fact, depression is the most common reason for seeking medical attention. So all of these signs and symptoms here, it's because I'm old. Really? Really? Okay. Not the case exactly. So a person is actually going to ignore these signs and symptoms, and they're going to see you because of depression. So double check a good psychosocial assessment on somebody who has a high risk factor for developing hypothyroidism. Oh, I forgot to mention who gets it more. Women. Women are affected 7 times more than men are. So this condition is generally, stays within the female gender. And if you're between 30 and 60 years of age, you're likely to get it. That's not saying an older person can't, or even somebody who's male, but if you're going to see a case, it's probably on a younger female. Okay, I think we're good on the signs and symptoms and clinical manifestations. Oh, anorexia. That's right, they don't want to eat. But they're gaining weight, I'll tell you that. I just wanted to give you an example of what mixed edema looks like in the face, or if you had somebody with hypothyroidism, what would their appearance be? These are 2 separate people, by the way. That's probably pretty obvious. But this girl here, as you can see, her eyelids are kind of swollen. Her cheeks are swollen. If we were to look at her hands and her feet, they would also be swollen. But you have sort of a rounded type of appearance here. This female received treatment, because remember, females are 7 to 10 times more likely to develop hypothyroidism. And anywhere in the age of, I think it's 30 to 60, you're going to be likely to develop it. But anyway, this female received treatment, and this is her a few years later. Remember, the myxedema has got some other contents in the cells, so it's not hitting edema that they have, and it takes a long time for them to get back to their normal appearance. Pretty girl here. Now, this patient down here, I would like to give as an example of somebody who has pretty severe myxedema. They have a severe case of hypothyroidism. You know, these symptoms develop over a long period of time, and this is a pretty severe condition. In fact, this patient, this is a case in Italy. She came in to the ER having some confusion, some lethargy, and some passing out, and that's related to her hypotension. But anyway, as you can see here, her hairline has receded. It's very thin, fine, it's brittle. Her eyelids are completely swollen, as well as her cheeks and her face. Remember the nail changes and the integumentary changes that happen with hypothyroidism? Thick, brittle nails. That's from not just missing one pedicure. That may be several pedicures missed. But anyway, they'll have some dry, flaky skin and actually thickening of the skin. That's called lichenification. So it kind of looks like thick leather or like alligator skin. But yes, this is very characteristic of hypothyroidism. So this woman received treatment, and it does take time for them to return to normal. And this is her within 1 year. You can still see it's the same person here, but her eyes are not as swollen. She doesn't have that periorbital edema. She doesn't have, well, you can't really tell, but a goiter anymore. And then as you can see here, she doesn't have the edema on her feet. And her nails are painted. So hypothyroidism is slow. The effects on the body, it changes everything, absolutely everything. So this is the same table that I had for hyperthyroidism, but if you notice, these are the three that we want to focus on for hypothyroidism. If you have a diet that's low in iodine, your TSH is going to be pretty normal, maybe even on the low side. What's going to be low here if it's diet-induced hypothyroidism, meaning not enough iodine? You're just going to have a low T3. But this is the most common hypothyroidism, and this is because the antibodies actually attack the thyroid and block its ability to take endogenous TSH. So you're going to have low free T3 and free T4. So they're going to be very low, and the body is going to know that it doesn't have enough T3 and T4. So it's going to say, make more TSH. Why aren't we getting enough T3 and T4 around here? So unfortunately, those antibodies block the TSH, so this will just continue and continue and continue and get more and more severe until you start giving somebody exogenous forms of Synthroid as an example. And this can occur if you are treating somebody for hypothyroidism and you draw their levels and you see that everything looks good, but their TSH is still high. This means that the body just needs a little bit more Synthroid to try to bump up the body's metabolic rate to keep up with it. Now, the book does mention that if patients are older than 80 years old and you notice that they have low T3 and T4, if they don't have any signs and symptoms of hypothyroidism, leave it alone. In fact, do not do hormone replacement for these patients. If they have signs and symptoms of hypothyroidism and you draw their lab levels and it looks like this, you are going to then treat them. It is a normal aging process to start dropping your T4 and T3 levels. Only treat them if they have signs and symptoms for folks greater than 80. Okay. you're going to send somebody, you can also do an ultrasound on somebody, but it won't be as good as a diagnostic test as a thyroid scan will be, because remember, you give these folks the I-123 radioisotope, and the thyroid is actually going to barely uptake the radioisotope, so it's going to be less than 5% uptake, and this is going to show the doctor or the provider that they have low uptake, therefore hypothyroidism. But once again, you can't do this scan if somebody is pregnant, and you do not have to do radioactive precautions for this person because it's not the 131 radioisotope. Okay, you can do an EKG. What are you looking for on an EKG? We know what to look for hyperthyroidism, but how about for hypo? Well, we're going to see sinus bradycardia, so the heart rate's going to be less than 60. Also, we're going to look for some arrhythmias. You can have arrhythmias with both types of thyroid disorders, but the bradycardia is very unique to hypothyroidism. Okay. Some nursing interventions that you're going to do, well, you're going to be checking this person's vital signs every 4 hours, and you're going to be on the guard for hypotension. And what you're going to also see with this, with the hypotension, is the dizziness, the position changes that occur, may make the person, even feel more symptomatic with the bradycardia. So these are kind of two bad combos. So we need to make sure that we don't give the patient any kind of blood pressure meds, maybe a rhythm med, but we're going to have to closely monitor the heart rate and the blood pressure. The person is going to be more prone to have bradypnea, and so make sure that their respirations are not less than 12. We need to make sure the person's still oxygenating. If they are less than 12, we may need to do an ABG and see if this person needs supplemental oxygen. Frequent orientation. They are very confused. They're intellectually slow. So this will take a while to fix. So just encourage family members that over a period of time, the person's mental status will improve. They won't slur their speech anymore. They won't have memory impairment. So just be very supportive during the time that this person is recovering. They're going to have very swollen legs, so make sure that you get those legs elevated to decrease the edema, and put on some TED hose. That also helps with the circulation. Those are those tight white socks that go either to the calf or the thighs. Nutrition. So these patients have problems with weight gain. If we would like to get them to get back to a normal weight, I'm not sure if they were, normal and then obese, or underweight and now normal weight, but regardless, everything is patient specific, but you would put them generally on a low calorie, high residue diet. And remember what high residue means? High fiber. This person has problems with constipation because their gut is slowed down. Slow. Make it fast. So you're going to put them on foods that get them moving, such as apples and oranges and prunes, things like that. Coffee. Laxatives. That's another thing we need to introduce into their diet now. Skin care. They are dry and they are scaly, so you are going to be putting some intense moisturizers on them after every bathing session. So make sure you do good skin care for them. Interning, because they're possibly, depending upon how severe the hypothyroidism is, they may be bedbound. So don't forget to turn them Q2 hours. Comfort, they are so cold intolerant. They are going to be freezing in summer. So make sure you put the person in layers, not just one giant winter coat, because they need to be able to take some clothes off depending upon if they go from outside to inside, or add on a layer here and there. No electric blankets. Electric blankets do provide warmth, however, they do make somebody more prone to hypotension because it vasodilates all of their vascular system. So let's stay away from the electric blankets, shall we? The psychosocial care, now encourage your patient that the signs and symptoms, the myxedema, which is probably the most distressing part, is reversible, but it does take, literally minimum to a year to see things changing. So don't get discouraged. Continue to take your medicine. Don't start double dosing. I've had patients say, when they have hypothyroidism, they start with 25 micrograms of Synthroid and they don't see changes, they don't feel normal, they still have low energy, and they say the doctor doesn't know what he's doing, and they'll start doubling or tripling their dose. Well, these changes take time. We must encourage our patients that. In fact, that is highly likely a test question, okay, about changes here in hypothyroidism. Just a hint, take it or leave it. What do I know? I'm just the teacher who makes the test. Medications. We're going to get on replacement therapy bandwagon next slide, but for this one here, I want you to know that sedatives such as opioids, other anxiolytics, those are going to have a very profound effect in these patients. So little is best. Just because of their metabolic rate, they're not going to take these medicines and have it wash through their system. It's going to float around in there. So please make sure that you use a little bit of pain medicine and anti-anxiety, all that good stuff. Even if they're going to surgery, the doctor or anesthesiologist needs to know their metabolic rate, so they give them smaller baby doses. There you go. That's that. Alright, once we find out that somebody needs replacement therapy, you are going to give them the synthetic version of, I believe, T3 or T4. That is Synthroid right here. It is lifelong. This person can, for the rest of their life, not go without this pill. So they always need to have refills on hand. They need to have a primary care doctor. This isn't just something that's an acute condition and then it goes away. So you need your thyroid to work with you, and that's until death do you part kind of thing. So whenever you administer the medication or when the patient takes it at home, it is the first thing that they take in the morning with a glass of water. No food, no other medications, especially not any kind of GI medications such as like Carafate or calcium, like Tums, calcium carbonate, nothing like that. In fact, if you take it with those medications, it's going to mess up this thyroid medication. So they need to take it before anything else, at least 1 hour before. So remind them, wake up, take the pill, wait an hour, and then take something else, whatever their other medications are. And that goes for you. If meds are delayed for an NPO, like say the patient's NPO for a procedure, and they come back and you need to give them the rest of their daily medications, you give them the Synthroid, you wait an hour, and then you give them the rest of the medications. That's very important. Whenever we begin therapy, we actually are going to draw their levels, and then we give them the lowest dose possible. If we give them too high of a dose, we can actually put them in a myxedema coma and cause problems cardiac-wise, which I'll get to down here. So give them the lowest dose possible and make changes after you get the lab work. So you start them off on, say, 25 micrograms. You do labs. Levels are still too low. So then you give them 50, and then you can go all the way up to like 250 micrograms, I believe, for somebody on this drug. For older people, you make changes every 1 to 2 months. Notice the difference in the frequency. Reason being is older folks, when they develop hypothyroidism, they actually have cardiovascular changes that occur along with it, such as coronary artery disease. So this is somebody that we cannot just bring their metabolic rate right back up, because the oxygen demand on the heart will come back up quickly, and we may give them cardiac arrest. So make changes very slowly in your older patients. Now, you can always go to the other extreme, because you don't know how much it will take for somebody to normalize. So you may go from 25 micrograms to 50, And next thing you know, they start developing signs and symptoms of hyperthyroidism. So they need to be aware. Now, if you notice weight loss, we are going to have some weight loss because the person is losing all of their fluid, but we don't need where they're skin and bones. That's the difference in the weight loss. They're going to have the tachycardia, the palpitations. They can even have a thyroid crisis where they have the tachycardia, hypertension, and the arrhythmias. So make sure the person knows the signs and symptoms of too much, the other extreme. Irritable, that's not down here, but they'll be irritable. If somebody has seizure medications that they also take, or they're on sertraline, which is for depression, and phenobarb for anxiety and pain, these drugs metabolize Synthroid very quickly. So you will actually be giving somebody a normal dose, and their body truly, because of these other drugs, only gets half or a quarter. So when a person has both Synthroid and these other drugs, no, you're not giving them at the same time, but you do need unusually higher doses of Synthroid. So just kind of make that note to yourself. So as I mentioned here, the cardiovascular effects on hypothyroidism is because the body has been without it for a long period of time. So whenever you begin this, start very slow. Your patient is at high risk when they're coming out of hypothyroidism to have a heart attack. So make sure that they just don't ignore any kind of chest pain or dyspnea. That's not normal. They need to get checked out. You would think that we would actually evaluate somebody, do like a heart cath or something on them prior to starting this therapy, but I guess that's a little too expensive and maybe invasive. So, older people though, this is definitely something you gotta watch out for. Alright, last thing I want to talk about is the myxedema coma. So this is quite scary and it's very life-threatening. It's a condition that occurs if hypothyroidism goes untreated for too long, or if your person who has hypothyroidism is just trucking along doing their thing, and then an illness comes along, a very severe one. Chemotherapy, they're receiving something for cancer, or for even arthritis, you can get chemotherapy. And then sudden discontinuation of thyroid therapy, or if you sedate or give somebody the opioids that are too much for this person. So this can occur at any point in time that you are at risk for myxedema coma. So the body is going into a state of stress, and you know what? They only get whatever dose of Synthroid we are giving them, and if it doesn't have enough, this happens. So you've always got to be on guard for this myxedema coma for your folks who have hypothyroidism. So what is it going to look like? Well, the first thing you're going to notice is probably the coma part. Their mental status just tanks, and it's probably going to be over a matter of a few maybe even a day to half a day of a time period with the onset of all these good stuff. So they're going to develop with a coma respiratory failure. They're not going to be oxygenating enough, so their respirations are going to be shallow and ineffective. They're going to shiver because they have hypothermia, and along with that hyponatremia, they may even seize. So seizures goes along with hyponatremia. The sugar, their body just isn't able to produce, or release more sugar from the liver, so they're going to have hypoglycemia. They just can't respond to that stressful state. So you're going to notice their blood glucose levels of like 50 and 40. And very common to hypothyroidism, you're going to have the bradycardia and the hypotension. So when you see all of this, you've got to act quickly, because this person can go into shock, and once they go into shock, the organs are just in a state of, shock, but they are very hard to recover once you go there. So first thing you got to do is get really frequent. In fact, first you're going to send them to ICU. And they're going to do very frequent temp monitoring. In fact, are they looking for hyperthermia or hypothermia? Please tell me you said hypothermia. Their temperature is going to be extremely low. They're going to be watching for arrhythmias and bradyarrhythmias, and whatever the arrhythmia is, they're going to probably give appropriate medication to adjust it or make it more fast. Make it faster. The respirations, if they're too low, you're going to intubate the patient and breathe for them through a machine and ventilate them at a faster rate. So they're not any longer going to be 8 respirations per minute. You're going to make them 12. Hypotension and bradycardia. ABGs, continue to be checking for respiratory acidosis, because remember, they're in respiratory failure. So we need to see if we are correcting them, because their body does not like to stay in acidotic state. Keep them warm. You're going to put a bear hugger on them. So keep them nice and toasty. No electric blankets, FYI. So if a family member suggests that, say thank you, but no thank you. We're going to be giving them fluids because they're getting ready to go into a shocky state. That's not a real word. That's nursing lingo, shocky. They're getting shocky on us. But they're going to go into a shock state, so we need to maintain their volume. Now, you are going to give them Synthroid for their, stressed out state, to help their body cope with all of the demands that it's now coming into. But please do watch for cardiac side effects. Remember, chest pain and dyspnea. Kind of hard to determine if your patient's, in a coma, but you can tell by watching rhythm changes if the heart is getting too stressed out. You can't fix them too quickly. Now, they should, if they're going into shock, their kidneys are going to quit producing urine because the body thinks that's not essential to excrete its waste. So if they're getting better, we need to be watching their urine output and watching their weight. We should start seeing them peeing again. We should see their weight start going down because they're getting rid of all that fluid. They're going to be hypoglycemic, so let's give them some sugar and let's give them some IV steroid therapy. This is to reduce the immune response, so the body is attacking itself. And whatever is underlying, if it's infection, antibiotics. If it's chemotherapy induced, stop it. Chemotherapy is so hard on the body. At this point, either the cancer kills the patient or the mixed edema coma is going to kill the patient. So what's going to kill the patient faster is the mixed edema coma. So you have to hang back on chemotherapy. And aspiration precautions because of their coma state. Okay, that is all about the hypo and hyperthyroidism. I'm going to briefly cover the parathyroid. This won't take too long. So I probably said initially about the thyroid.
Let's move on to talking about the parathyroid gland. So you've got 4 little nodules here on your thyroid, which are right in front, called the parathyroid. It's very unusual to have a parathyroid problem. However, it does happen, and you're going to know what to do when it does happen. When you want to talk about hyperparathyroidism, generally the cause is because of a tumor that's on one or all of them. Less common is just to have hyperplasia of some of the glands, and that's generally a response to some kidney disease or some other diseases that I'm going to speak to in just the next slide. But anyway, parathyroid, what do you do? Well, your one job is to secrete the parathyroid hormone. So it sends or signals are sent to it that say, hey, my calcium's too low or it's too high, and then the parathyroid will respond by either releasing or inhibiting the release of the parathyroid hormone. And its action directly goes to the bone and goes to the kidneys. So say it gets the signal that the calcium is too low, so it'll actually release it, and the kidneys will actually not pee it out as much. So they'll reabsorb it, and it will continue to float in the bloodstream a little bit more. And it's going to ask the bones to release the calcium that is contained inside of it. So it goes now into the blood circulation where the body is nice and happy. And then, well, that's kind of the gist of the parathyroid hormone. Now, I'll tell you that in a little bit. Got to keep it organized. So in hyperparathyroidism, it's very simple. You have an increase, an uncontrolled increase of parathyroid hormone production. So as I mentioned, some of the issues is the malignancy of the parathyroid. It's the most common reason. However, it can happen, excuse me, in chronic renal disease where the kidneys no longer respond to the parathyroid hormone. Say the person has, end-stage kidney disease, and it's not, it's not reabsorbing the calcium like it should, and so the parathyroid hormone will actually double work, triple hard. If you can do that, double work, triple hard. It's a lot of working to tell the kidneys to hang on to the calcium and not pee it out. So in that sense, it will actually go into overdrive there. And that other syndrome. Now this is kind of neat. I've seen this a bunch, but people who have lung cancer, it's crazy. The cancer will actually, even though it's primarily in the lung and it's all made up of lung cells, they will secrete a parathyroid hormone lookalike, and the body doesn't know the difference, and so the bones will start releasing the calcium, and the kidneys will start reabsorbing the calcium. So it's crazy. You will actually have a fake hyperparathyroidism situation. So that's kind of interesting to see. I see that on the oncology floor a lot. Well, anytime you have hypercalcemia, you will always have hypophosphatemia. These two are opposite of each other. They're opposite ions. If one's high, the other's low. If you have hyperphosphatemia, you're going to have hypocalcemia. Just write that down in your book and put that in your little noggin. Alright, clinical manifestations. So what is this going to look like? Well, your person is going to have constant bone destruction, and they're going to have a lot of bone pain. In fact, a lot of the weight-bearing bones, particularly the vertebrae, are going to have bone lesions in them because of the destruction and the inability to repair itself at a faster rate. So they're going to have like these little lesions everywhere, and that in turn is going to be weaker. So lots of pathologic fractures in these patients, which causes pain, kind of like an osteoporosis person. Inside the body and the blood vessels, the kidneys, and in different tissues, but these are the two primary ones, you're going to have calcium deposits. Nothing worse than having calcium in an organ, which calcium will make it hard and non-pliable, but in an organ where it should be nice and responsive. In fact, I know many times when we did arteriograms on people, the calcium deposits would highlight a vein or an artery where normally you wouldn't see it, but it kind of shows up like a bone. It's kind of crazy to see. But yes, that would actually cause somebody to have some higher blood pressure. So it takes time for this to develop, but if you do see calcium deposits, that means this person's had long-standing hyperthyroidism. Kidney stones, anytime there's an excess of calcium, you could have some kidney stones. What'd I do? Here we go. I think I messed up something. Kidney stones. Anytime you have an excess of calcium, you are more prone to develop kidney stones. So ask the patient about their history of kidney stones. They'll probably have a nice story to tell you about that. Muscle weakness. When the muscles are just, they have access to too much calcium, they're going to be extremely weak, and in fact, when I say extremely, I'll say severe muscle weakness and decreased deep tendon reflexes. They're not going to have any numbness or tingling, or around the mouth, because that's with hypocalcemia, which is signature of hypoparathyroidism. But anyway, they're going to have some severe muscle weakness. Cardiac arrhythmias, the heart is not very happy. We are going to have some dysrhythmias and probably a shortened QT interval. so you have to get them on a monitor. They are going to have some psychosis and mental confusion, so just kind of pick up on that. We're going to have constipation, anorexia, and some nausea, vomiting, because the body is not happy when it has all of this calcium. That one is just something you're going to have to memorize. I can't come up with a little jingle for you on that one. What diagnostic levels or tests are we going to do? Well, if you do an x-ray, you're going to see that the bones are very thin, and they're going to have these bone lesions all throughout the long bones in the body from when the calcium has been taken there and been put in the bloodstream because of the excessive parathyroid hormone. You can draw straight parathyroid hormone, which, take a guess, is it going to be elevated? Yes, it's going to be elevated in this condition. Calcium, is it going to be elevated or lowered? Elevated, exactly. And phosphorus, is it going to be high or low? Please tell me you're saying low. That's very good, because these are always opposite of each other. So telltale signs. Now, we can draw a urine cyclic adenosine level. This is used to indicate if it's a primary type of hyperparathyroidism. So this will let the provider know that it is, not just a case of, hypercalcemia, but they'll know that, okay. Some of the nursing considerations, well, surgery is generally what has to happen. And you're going to care for that person. If you want to visit slide 8 again and torture yourself, figure out what I said on that again, because I apologize, I do go on and on. I know it, and I can't help it. But check out that slide, and you're going to care for this person who gets surgery just like you would who's had a thyroidectomy. So that's on slide 8. We are going to give them lots of IV fluids. In fact, it's going to be about 5 liters per day. That's a pretty high fluid rate. In fact, you're probably talking like 200 milliliters an hour. In addition to that, we're going to give them furosemide. So this is going to make the body pee out some more, not potassium. Your potassium will go too, so you got to watch out for that. But your calcium will go with Lasix or furosemide. So that's a positive effect. So anytime you give somebody, lots of fluids and you're giving them diuretics, make sure you monitor their cardiac function. Is their blood pressure normal? Is it high or is it low? We don't want them to tank, but normally your person's going to be a little bit more hypertensive. Do serial EKGs. We want to make sure that the person is, their QT interval is becoming more normal, and then it's not starting to widen, which would be a sign of hypocalcemia. So we're going from shortened to normal, and we'll hopefully stay there, not go even wider. You're going to very frequently draw serum calcium levels, and we want it to decrease, but if you have any, I probably should have put sudden here. Sudden decreases, so like major drops, 2 points, we're going to be probably calling the physician, because our treatment is a little too effective, and we need to transition somebody from abnormal to normal slowly. Body took a while to get to this point, so we need to take a little while to get it back to normal. Diet changes? Oh no. Is that a typo? That is. Low calcium diet. These are foods right here that are very high in calcium. In fact, this is one of the highest, molasses. So tell them to stay away from this during the time that they have hyperparathyroidism, because they're going to be, always in a state of having calcium problems. So strains urine for stones. Make sure that the urine is free from them. If you can, catch them and send them for analysis, but they're going to show that they're a calcium type of stone. If the calcium is too elevated and the patient is symptomatic, you can give them IV phosphates. They do not have to be in the ICU to receive an IV phosphate, but just know that that's always an option, because we give that on the floor, I should say. So there's a lot of C medications floating around out there. There's, the calcitonin, the cinacalcet, I think you guys have looked up another one. What's that called? Calcitriol. So make sure you get those straight. Okay, so I know we are an hour and 41 minutes in, but I promise we're almost done. Stay with me. Run the race. Finish. 10 more steps and we're done. We're done. Okay. So hypoparathyroidism. This is when the parathyroid hormone just is not produced anymore. The most common cause is the iatrogenic, meaning the parathyroid hormone has been, cut out. It's absent, either during the thyroidectomy or because there's a tumor and they had to take it out. But this is the most common reason, is because the parathyroid is not there anymore. There is the idiopathic reason why you have decreased parathyroid hormone, and that's, really we're unsure of why it happens. It could be autoimmune, but they do have some relationships when it's paired up with like diabetes and adrenal insufficiency and I believe chronic kidney disease. No, not chronic kidney disease. Take that back. So it can happen, but it's generally related to something autoimmune where it quits working. Now, another reason, uncommon, but hypomagnesemia. So your person has some malabsorption syndrome, some chronic kidney disease, and they're going to have problems keeping their magnesium level up. And this, that they're not really sure how, but it just, the parathyroid doesn't secrete the hormone anymore. So you unfortunately have calcium being lost through the kidneys, or it's staying in the bone more than doing anything else. Okay, so that's why you can have hypoparathyroidism. Clinical manifestations. So if you do not have enough parathyroid hormone, you are not going to have any calcium coming out of those bones, and you are not going to have any calcium being retained by the kidneys. It's just all going away. So what you're going to have is, first sign, tingling and numbness in the hands and fingers. It's going to feel like if you ever sat on your leg long enough and you just get that like weird sensation, that's what it feels like in their fingers and in their hands. So this is early on. The person will have, if they have a moderate hypocalcemia, a positive Vostok sign. In fact, I looked that up. That's how you say that, Vostok. They're going to have a positive Vostok sign and Trousseau sign. They are going to start exhibiting some tetany, so their muscles are going to be kind of twitchy. They're going to be jumpy. You're just going to notice that things are beginning to, kind of spaz a little bit. They are going to have some irritability to psychosis. Now, if you notice, this is kind of similar where in hyperparathyroidism you have psychosis and some mental confusion. So in this case, it can be the same. So they're going to have mental status changes in both of the parathyroid extremes here. But moving forward, if you notice that your person has severe muscle cramps, like really bad Charlie horses, the hands and the feet, they're both spazzing, it's pretty uncontrollable, and gosh, God forbid, but they seize because of the hypocalcemia, they are very severe and they need IV calcium gluconate, pretty L-stato. But that's severe. I probably should put that down here for last, but whatever. Alright, so other clinical manifestations, a weak, thready pulse, and generally a slower heart rate. If they're severe, they can also have, if they have severe hypocalcemia, they can have severe hypotension. So this person's probably going to be getting some fluids, huh? And this is direct opposite of the hypercalcemia. And hypocalcemia, you're having prolonged QT interval. The other, when you have high calcium, it's shortened. Anyway, we have prolonged, so watch the EKG. The bowels are going to be really fast. In fact, this person's going to have some diarrhea, some cramping, and just nothing that they eat will stay, in their system for long. So probably some malnutrition and weight loss. can see these itty bitty little words, this is what you're going to do for this person. First, you're going to give them some drugs. You're going to try to correct the hypocalcemia. You can give them oral supplements if it's not too severe, such as calcium carbonate. They also have, what's it called? Old ladies take it. Oscal, that's calcium, something, but it's calcium. So you can give them oral or you can give them IV. Just make sure they're on a telemonitor if you give them the IV one, because you can put them in hypercalcemia. Anyway, drugs that enhance calcium absorption, this is kind of neat. You guys did a drug card on this one called calcitriol. This is an active form of vitamin D. Now, I think majority of your calcium, majority of your calcium comes through your gut. And you make vitamin D, your skin does, doing all its little thing, doing its thing, getting out the sun. It makes maybe about 10% of the vitamin D that you actually need. However, the food that you ingest also should have vitamin D in it. And what's great is the vitamin D tells the intestines to absorb the calcium. So we want a person who is low in calcium to start getting excessive amounts of vitamin D. This is great because it's basically unlocking the intestines so all the calcium that somebody ingests gets into the bloodstream where it needs to be to correct this problem. So we're going to start giving a patient with low calcium hypoparathyroid calcitriol, which is fancy for active vitamin D. If your person has hypomagnesemia, and that's what's causing the low parathyroid hormone levels, you're going to start giving them some magnesium and hopefully correct their malabsorption syndrome or adjust their diet if it's from chronic kidney disease. Their muscles are twitchy, and sometimes this can be very stressful for a patient, so you can give them a muscle relaxer. Just know that you're not fixing the problem by giving them a muscle relaxer. You're just doing symptom control here. And this is generally short term. Nutrition. So what are we going to do? We're not experts in nutrition. Some people may be, but go ahead and order a dietitian consult, because they're going to figure out what the patient's preferences are and try to arrange for them to have a high calcium diet. So you're getting more intake, through the gut, and through giving them the calcitriol, they're going to be absorbing that calcium, and we're all going to be okay. Seizure precautions, because remember, if they have severe hypocalcemia, they're going to seize. That is not a fun thing to be around. So make sure the rails are padded, the bed is, the lowest position. That's kind of a given. But suction needs to be at bedside. Calcium gluconate needs to be at bedside, like a whole container, an ampule of it inside the room. And make sure you have oxygen available in case they seize. You can reverse it instantly. Short seizures are not bad. It's when they have a long seizure, greater than like a minute or so, and they turn blue and stay blue, but that's not preferred. Reduced stimulation. So remember that this person's muscles and everything in this hyper excitable state, and they're twitchy as well. So let's give them a quiet room, limit visitors, adjust lighting, use a soft voice, kind of just get in, do your thing, and get out, because this person doesn't need to be at any high risk to having more spasms and even a seizure. But do check on them. Safety, their bones, because their serum calcium is low, that the bone calcium is also going to be low, because that's the reservoir for calcium. So they're going to be more prone to pathologic fractures. In fact, right here, always check this person for the range of motion, the bumps and depressions. So this may indicate that a fracture is actually present. So you may need to stabilize that bone in the event that somebody has this condition, and you're just doing your little assessment, doing your thing, and they can't lift their arm over their head, or they can't hold their arm up. Check into that. Don't pull on the body. Please use a lift sheet. You shouldn't ever pull on a body, but I guess I feel the need to say that. Okay, so that is all with hypoparathyroidism. This is a lifelong condition. You know, unfortunately, they are just going to have to take medication therapy forever and continue to have calcium levels drawn. Kind of like hypothyroidism. That's just how it is. This is probably you right now. That's a lot of information I just threw at you. So I completely understand. If you want to take a break, great. In fact, I recommend it. But at this point, I have a few more slides that has some questions for you that you may be able to test the information you just learned. So if you need to walk away, I completely understand. But I do want you to come back and try to take the challenge questions, okay? I'm going to let you read it. I'm going to pause. You may want to pause the video, and then I'm going to go over the answer. Okay, so the answer for this one is hypothyroidism. So most cases of the hypothyroidism in the U.S. occur because of thyroid surgery and because of the radioactive iodine, that 131 that we give people. Okay. Notice that she is within 36 years old, female, tired all the time, muscle aches and pains. That's that low metabolic rate. She's got bradycardia, hypotension, and what's that right there? Hopefully you're saying myxedema, my little smart bunnies. I'm going to let you read the question. Please pause because I'm about to reveal the answer. Alright, so the result the nurse expects to see is decreased T3 and T4 levels. What's going on here is that she's got hypothyroidism. We are actually not going to see normal. We're going to see an increased TSH. This right here is hyperthyroidism, and we are going to see this in hypothyroidism. And once again, you're going to have an increased TSH. Read the question. Please pause, get your answer, because I'm about to reveal it. The area where this person needs more teaching is D. This is a lifelong medication that they will take. So until death do you part with Synthroid, you will be on this medication. Sorry, Charlie. Remember, their gut is going to be very slow with hypothyroidism, so they need to get it going. So this is why B is not a good option, because that's true. We'll read this one, because the answer is... Okay, so you want the answer now? I bet you do. How bad do you want it? Okay. It's B, C, D, and E. All of those things you're going to teach your clients. Your diet should be high fiber and plenty of fluids. That's why it's not A. And you could probably rationalize why you need to know their sleep time, mental status changes. Synthroid needs to be taken in the morning by itself, especially not with GI meds. And this shows an undertreatment of hypothyroidism. Question time. Read it. Pause me. Alright. So, the finding requires immediate attention, and if you answered A, you are correct. All of these are bad. Just saying. In fact, these are all expected findings with hyperthyroidism. This one is the impending thyroid storm. That's the one you got to call the doctor on. Okay? Don't worry about it being question 3. There is no question 2. You didn't miss a thing. Read the question. Answer is A. Avoid extending the patient's neck. That's where they're kind of in the looking up position, where their neck is really, their chin is up in the air. This one, you need to be assessing their voice every 2 hours, just to make sure that it's not getting worse. You know, there's no edema, nothing like that. they don't. I mean, we do want them out of bed, but initially, this is probably going to put them in a 90-degree angle. Let's put them in a semi-Fowler's initially, and administering oxygen via nasal cannula. That's always good, but we want to make sure that it's also humidified. So this one is another good option. They probably won't even need it. Anyway. Alright guys, that is it. That's everything you need to know about the thyroid and the parathyroid. I can imagine this is you sitting there trying to pay attention to all this. You may have to watch it a few times, or even listen to it a few times just as you're doing your thing in the day. This is a lot of information, and to get it to sink in your head, you kind of have to do practice questions. So I'm going to upload this PowerPoint tonight, and I'm going to put a link with it. So once you're done and you feel comfortable with this information, you really need to try some test questions out to see if you really understand it, okay? If you have any questions, use the discussion board. Thanks for listening. I don't know if you had an option, but thank you for listening. All right, thank you guys.